All right, good morning. We're going to start. I would be talking about kidney transplantation as a treatment for ESRD and how we select patients. I like this quote from about 100 years ago because at the time, written by Osler, who is considered the father of modern medicine in the US, it shows the state of affairs at that time. This is not really a statement of ignorance. It's more of an expression of how bad things were and still are for much of the world, because this was written at the time when the Nobel Prize for the development of the surgical technique was already given in 1909, and this was around the time where in the same institution as Osler was, which is Johns Hopkins, the first form of a dialyzer, which is pretty much similar to what we use in today's form, was first developed. So he knew what's going on, but it shows you how bad things were at that time. It took another 50 years, and then he was proved wrong. And fortunately, since then, we have an effective treatment for kidney failure. Kidney failure and chronic kidney disease are common, especially this is the United States data. In stages, this is the early stages, 1, more advanced stages, stage 5, you have a lot of CKD. If you add all of this up, it comes to about 15% of the US population. And each color is a different time period. A lot of it has not changed, but the middle stage, you could see it's kind of going up. But a lot of these patients, you're talking about millions of people, do not really develop kidney failure. They die before they do so. That's why you actually see much smaller numbers down here. And what do they die of? Usually heart disease and stroke. And that is because the bulk of chronic kidney disease happens in the older age group. And here you see as much as a third of the population could have chronic kidney disease when you go, and most of it due to diabetes and hypertension. This is the hypertension, diabetes, this one is hypertension. So chronic kidney disease is by and large a disease of old people, and it's also due to hypertension and diabetes, and it's also a disease of largely poor people because that's where diabetes and hypertension are most common in. The most severe version of chronic kidney disease, end-stage kidney disease, is now in hundreds of thousands. We have about 700,000 here, of which about 200,000 are people living with kidney transplants. And just look at the curve. It's not letting up. It's still going. Now, we talk about today transplantation because we are saying transplantation is good compared to dialysis. And is that true? And we know it is true for people who we think are candidates for kidney transplant because of this study that was done about 20 years ago. And what this shows is if you are on the wait list for waiting for a kidney versus getting a kidney transplant, your risk of death would be, when it's equal, is this line. If it's above this, it means you have higher death from transplant. If it is below this, it means you have lower likelihood of dying from transplant. And right around the time of transplant, you would have a slightly increased risk because you're going through major surgery and all the complications that come with that in a very sick person with organ failure. After that, your likelihood of mortality goes down. So you're incurring livelihood advantage, survival advantage as you stay longer. And that gain in survival applies pretty much to everybody. It's not really only for the young. Even people in their 70s do benefit from kidney transplant. Now, the question is finding out the ones that would benefit from kidney transplant. That's where the selection comes in. So to know who is likely transplant candidate, the best way to think about is who cannot be a kidney transplant candidate. And those are obvious. One is you don't want people who could not have transplant because they have active infection, because you give them immunosuppression, things are going to go haywire. You can have, for the same reason, people with cancer, people who have untreated psychiatric disorder or uncontrolled psychiatric disorder, because that would interfere with their ability to take care of themselves. And Dr. Grusner mentioned how people who could not adhere to therapy and are losing their graft because they cannot take medicine should not get a second chance. That's what we're talking about. Now, it's a little tricky when you're talking about adherence, because what is considered non-adherence for dialysis may not necessarily translate to non-adherence for transplant, because dialysis is a very, very tough thing to deal with, especially for your younger individuals who have some active life. So if you're going to have a social life, you're going to eat, living on a 1 liter fluid intake for a day is not easy for a 20-something-year-old person, or eating a lot of food that is restricted. So what we consider non-adherence for dialysis may actually turn out to be okay on transplant, because these are things that could actually go away once you have a working kidney. Some other things like non-adherence with medication, not following your doctor's advice when it is something that could endanger your life. The extreme versions is what we're talking about. So there is a lot of judgment that goes into this. If you are an active substance abuser, the same thing as psychiatric illness. You probably are going to look for your high and not necessarily for your health. So that's something you have to overcome before you become a transplant candidate. The rest is whether you have a healthy body to transplant. So if you have major organ failure, if you have terminal lung disease, terminal heart disease, terminal liver disease, you're not going to be able to get a kidney transplant only. In those situations, you have to have either a combined organ transplant with kidney, or you're not a transplant candidate if you're not eligible for the other organ. And then you have to be able to do the surgery. And to give you an example of what that means, this is somebody who has this large veins all over the abdomen. And the reason this happened is because this person got an IVC filter some time ago, and that occluded the vena cava. So transplant may be possible in this situation, but by and large, it's probably kidney transplant is out in this situation, or it's extremely dangerous situation to try. So part of the evaluation when they come to clinic for transplant evaluation is, do they have an anatomy that allows transplant? It's not just this, it is the vessels, it is the abdomen, and when the surgeons talk about what the evaluation is going to be like, they would go over that. What do we do to see if a transplant candidate is a candidate? We have some routine tests, and basically boils down to, do you have any active infection, and do you have any cancer, and do we know what kind of kidney would be compatible with you? So we do tissue typing, and part of tissue typing is blood group typing. And we screen for common infections, most of them viral, but a few chronic infections. But you still have to look for other infections. Diabetic patients could have raging foot ulcers that they may not show you, and they may not even know because they don't have any sensation in their feet. So you have to have a high index of suspicion for what could go wrong in that specific patient. And this is kind of this garden variety of infections we look in everybody, almost everywhere in the world. But depending on where some patients come from, and some other parts of the world, depending on the epidemiology of the infections, you have to look for infections that you would expect to be common in that population. People from Latin America, for instance, Chagas disease, which is a parasitic infection, is common, so you have to look for that, and so on and so on. So you have to know not only the tests, you have to know the patient. You have to know where they come from, what kind of life they have, and you have to see what could go wrong with them. Age and gender appropriate screening, meaning your mammogram for women over 40 or 50, whichever recommendation you believe. You have to look at your pap smear for anybody who is sexually active, and colonoscopy, PSA, and so forth. Now, this is what we do in everybody. And depending on any disease that the candidate may have, then you add on more things. If they have risk for heart disease, you're going to do heart test. If they have lung disease, you do more. So it's more involved than this, as most of you know, especially the ones who deal with this on a day-to-day basis. Once you get them ready, you have to transplant them. And what do you expect? This is what you expect. Where you get the organ from matters. The best outcome is the kidneys, other than identical twins, the kidneys you get from an HLA identical sibling, meaning you got the same half from both parents. So you're almost the same. You're as close as you can be to that person. And any other live donor is in the middle, deceased donors. And this kind of this is from about 2 decades ago, but this is pretty much the same story now. You have about somewhere between 10 to 15% separation between live donor and deceased donor long-term outcomes. So getting a live donor transplant is way better than getting a deceased donor transplant for a number of reasons. One, you're going to have a kidney that lasts long. The other thing is the complications from transplant, but generally are less, especially that come with poor graft function and immediate graft dysfunction and the associated problems that come with it. You keep the kidney working at better function longer. It's not just the kidney lasts long. While it's working, it has better function generally. And they spend less time on dialysis. This is very important because the longer you stay on dialysis, the less benefit you derive from transplant. So live donor transplant recipients do better, not just because they get a good kidney, it's also because they get less dialysis in general, because most of people who get live donor transplant tend to get from family members usually early on, and they don't wait on dialysis for longer. And it's generally cheaper because you do not have the complications that come with having deceased donor transplant. You don't have dialysis after transplant. You don't stay longer in the hospital. And it's a happy experience for everybody. The surgeons don't have to wake up in the middle of the night. It's all planned. The patient is happy. The donor is happy. The family is happy. It's a happy experience for everyone. So we have to advocate for live donor transplant as much as we can. We used to have a category of kidneys called marginal kidneys, extended criteria donor kidneys. And why do we use them? The reason is, just like the graph I showed you in the beginning, you do derive survival benefit by using these kidneys. And the risk around the time of surgery goes up when you get these kidneys. Those kidneys do not work very well early on. So, and you're using it in people who are generally sicker. That's why you're using this less than ideal kidneys. But on balance, once you survive the initial period, you do well after getting these kidneys. We no longer use ECD or marginal kidneys. I'll kind of explain what terms that we use in the next slide. And the other thing we have to be aware of is, now, the time to offset this excess mortality you have takes much longer when you are using the less than ideal kidneys, high KDPI kidneys or ECD kidneys, whatever we call them. It may take as much as 3.5 years before the risk equalizes. So you have to select, you have to be even more conscious of the patient you select when you're using these kidneys, because you have to give these kidneys to the right patient if they're going to do well. And who are the right patients? Generally, the older patient, older than 40. Now, relative risk means if it is 1, it is the same as staying on the wait list and getting a good kidney. If it is less than 1, it means you're getting survival benefit. If it is more than 1, it means you're losing survival. And diabetic patient, this is kind of paradoxic. Why would diabetic patients who are generally sicker end up having survival from not getting a good kidney? And the thing is, the long dialysis in combination with diabetes is usually not a good mix. The earlier you get a transplant for a diabetic patient, the better off they are. Dr. Sagi and Dr. Grusner probably wouldn't like this, but even in patients who are eligible for pancreas transplant, the benefit by and large comes also from the kidneys. It's not just the pancreas. I'm not saying pancreas transplant does not have importance, but treating uremia is key in people who have diabetes and kidney failure, and correcting all that. it doesn't really do well for people who are sensitized. If your PRA is a measure of how sensitized you are, meaning you have antibody against the donor or other people who could be donors, and if you have a sensitized patient, you may not do well. And the rationale is, if you think of it, if you have a bad kidney to begin with, and then you have a patient who could likely reject it, you don't have much reserve to survive that rejection. And it only works, obviously, if you have a long wait time. I showed you how long it would take before you actually equalize benefit. So if you are in an area where you get a kidney within a year, it doesn't make sense to get less than ideal kidney. You can get a good kidney in a short time. It's not going to happen if you're it only is a good idea if you have a long wait time in your area. It's a no-brainer for our situation where the less than, I think, a quarter of people in our area get a kidney within 5 years. So we are one of the longest wait time areas in kidney transplant in the country. The same thing in most major metropolitan areas. Now, quick translation of the terms that you have heard thrown around, KDPI and EPTS, because we've gotten rid of extended criteria donor, marginal kidneys. Those are old terms, but they are still part of the literature, so we have to know about them. KDPI and EPTS are things we use to assess donor quality and the health of the candidate. So we switched to these terms for two reasons, the KDPI. One is ECD is kind of a two category, good kidney, not so good kidney. So maybe instead of having two, now we have about 100 categories. And the way we do that is we take all kidneys and rank them from 1 to 100 based on how likely they are going to survive a certain amount of time. All of these kidneys are transplantable kidneys. If you have one, it's a good kidney. If you are 100, you're kind of on the other end of the spectrum. EPTS is the same thing. It's how likely you're going to survive after kidney transplant. If you have one, you're the best candidate. If you're 100, you are the candidate who is likely to have complications down the line. And based on this, you're going to decide, not we, but the rules are that the kidney would be allocated based on the kidney quality and who it is going to go to. So there are 4 tiers that the kidneys are allocated. Kidney allocation is going to be discussed down the line, so I'm not going to dwell on this very much, but the best kidneys go to the people who are most likely to survive longest. So it's what's called the 20 to 20. The one in kind of the next category, they go preferentially to kids, but they're open to everybody. So most of the good kidneys, kind of the best kidneys, 35 percentile or better, are going to young people, unless there's no young people, and then it goes to an older person. And the middle group is open to everybody, all adults. And this one is an opt-in. So if you have a KDPI above 85, you have to say, this is a kidney that I want, and I want to be open to this. Generally, we give these kidneys to what I showed you. Older individuals who have some conditions that puts them at a higher risk of dying on dialysis, and they may derive benefit. So they shouldn't be too sick, they shouldn't be too well. And you have to find that middle. And it's not as easy as we say it is. And the other question you have to think of is, when should we transplant? And the best time is to transplant before somebody needs dialysis. Why? The longer you are on dialysis, the more your graft is likely to fail. We don't know why, but generally it's better to transplant somebody before they are on dialysis, if possible. If not, even if you are on the wait list, you still derive the survival benefit. I'll talk a couple of subsets of patients. One is hepatitis C, the other is HIV. And hepatitis C patients, the question is, you have a condition that could cause death and liver failure. Should we give you a kidney too? And it could also cause kidney failure. And this was an older study, but very well done study. And what they did was they selected people who have hepatitis C. They compared them with matched group of hepatitis C negative individuals on the wait list. And if you see that mortality is higher in those who have hepatitis C, and about 40% higher when you adjust for other things. But if the question you should ask is not really whether people with hepatitis C die more, the question is, would they die less if you give them a transplant as compared to having them wait on dialysis? And the answer to that is they actually do better with transplant. So this is basically, one is hepatitis C positive, the other one is not. They're almost indistinguishable. So this is around the time of transplant, everybody's risk goes up, and afterwards it goes down, and they derive similar benefit as everybody else. So hepatitis C positive patients, since the early 2000s, there's no question that you should transplant them. The only question is what kind of kidneys you give them, what immunosuppression you give, how you select those patients who are kidney-only candidates. And if they do not have advanced liver disease, they do very well with just kidney only. Now, this has been replicated in many studies. Each one is one study. As you could see, Pereira is probably the biggest study. That's what I showed you earlier. And on balance, again, they do derive benefit. Here it is survival. So the survival is better if you are on this side of the slide. So patients who have hepatitis C do very well if they get a kidney transplant, as long as they're a kidney-only candidate. Otherwise, they should get a liver kidney. Things have changed a lot because now hepatitis C is a curable disease. And we know that is so from non-transplant patients, and there's a lot of evidence coming even among transplant patients that it is so. So patients who have hepatitis C can be cured even after getting transplants. That much we know. The only thing now is when to treat. So we're changing from whether hep C should be transplanted to saying hep C should be transplanted with hep C positive kidneys only, and then saying hep C kidneys to hep C kidneys is a bad idea because most of them do not work. And then now saying it doesn't matter, we're going to give you even hep C positive kidneys to hep C negative patients, and we'll treat you anyway, just like we treat CMV positive kidneys and we give it to CMV negative recipients, and we treat them and they do fine. So it's become a complete turnaround, and we have to be aware of that. And our program's approach is going to change very soon. We already have, I think, turned one patient on as a hep C positive person willing to take a hep C positive kidneys, and that's where we're heading, and that's where the rest of the world is heading to. If you have questions in the middle, please jump in.
The medication that you take for hep C, there'll be no trouble giving them immunosuppression, steroids, or whatever, keep the kidney?
We have now so many agents that are directed against hep C. We have a choice that would work for transplant patients very well, yes.
Okay, thank you.
And then you're right, there are two things to consider. One is kidney failure. Some of them are hard to take with kidney failure. Some of them interact with the transplant medication. That was the problem with the earlier versions. The newer versions are fine.
Okay, thank you.
Now HIV, you have to select again the healthy HIV patient. They should be on HIV medication and they should be adherent to that, because otherwise people still die of AIDS when they have resistant HIV. So you should select the subset of HIV patients who are doing well. And what does that mean? Their immune system is good, they are on treatment, they did not have infection or cancer that could not be eradicated. In that situation, you could transplant this patient, and they do just well as anybody else. There is a slightly increased risk of rejection, so we're using more potent immunosuppression in this patient. There is a risk of drug interaction. We have to follow them very closely. Just to give you an example, tacrolimus, we give twice a day for the rest of patients. HIV patients who are on certain medications, they take it once a week. And you see the difference between once a week and twice a day. This is going to be a talk by itself. How do patients go through this evaluation process? They come referred, you have tests, consultations, and you go on until you resolve all pending issues, and we say, okay, they are good for listing, they get listed. If they get a transplant, right away. If you're a live donor, then it's all done. If you are waiting for a kidney, this cycle goes on every year or however often we have to do that. And the coordinators spend a lot of time, and the physicians and everybody else a lot of time. This is a huge amount of work, and it takes 10 years for this to pay off. So you could see how much work we're doing on this. Long-term management, Dr. Broad is going to talk about this. I would just touch on things related to immunosuppression. When you have, in a way, what we're doing is taking people who have kidney failure, giving them something that would improve their kidney function, and pretty much turning them into AIDS patients. So a lot of the things that we're doing in transplant is actually borrowed from HIV treatment or kind of developed in parallel. Rejection happens, but much less common than it used to be. Infection is kind of the beast with immunosuppression and kidney transplantation. And we have to worry about cancers because some cancers are much more common than in transplant patients than in people who are not taking immunosuppression. But by and large, these people do well in all aspects. And you can have long-term medical conditions that could develop. Rejection is now in single digits. It used to be, go 20 years ago, 20, 30 years ago, you're talking about 20, 30, 40% rejection. Now we're talking about well under 10%. And a lot of it is actually some kind of antibody, especially early on. And when they're cell-mediated, it's probably because they're not taking medications. So the medications are so good, and it's for people who are taking it, and we know how to use it nowadays, that rejection has become a very rare event, except in this high-risk patient, we intentionally are crossing immunologic barriers. But the good thing is we can turn most of this around, as we've spoken earlier in the opening session. Unfortunately, we don't have anything for chronic rejection, and this is an active area of research. Hopefully something may come of it. I'm just throwing this to make you aware, especially for long-term management. A lot of medications interact with immunosuppressive medications. There is no reason to memorize this. The best thing to do is tell the patient that if they're going to take any new medicine that they are taking right now, they have to tell us, and we have to check it. You cannot remember every interaction possible. Nowadays, it is very easy to get this information. It's online. The Downstate website, if you go to HealthBridge, there is a link, and in that link, you can actually have a pharmacopoeia that will show you where to find these interactions. It gives you plain what to do and what not to do. I want to emphasize this concept. This is something that the transplant infectious disease people like. It's called net state of immunosuppression. The thing that puts our patients at risk is not really immunosuppressive medications only. It also is what's going on with the patient, meaning if they have chronic diseases, they have heart failure, liver failure, if they have lung disease, any major organ illness is going to put you at risk of infection. If you have any breach in barriers, meaning you have tubes, you have IV lines, that is another reason for having infections. Vaccination status is one thing that's kind of overlooked. We have to vaccinate our patients, ideally before transplant, but even after transplant for most of these conditions, because the risk goes down based on some of the conditions that lend themselves to vaccination. Then the worse the organism, the worse the risk of infection. And then this is one thing we have control over. Chemoprophylaxis, meaning there are things we can treat these people with so they do not develop infections. So you have to take all of this into consideration. And the other thing, when you say exposure, is where they go, what kind of animals they keep, what kind of hobbies they have. I remember one of our patients, for the people who are on the transplant nursing floor, we had a patient, a couple of patients who got fatal fungal infections because they were having constructions at home and they got fungal infection from whatever mold was growing in their house. So it's not just knowing medicine. Again, you have to know your patient very well. You have to know what's going on in their lives. It's also good to know the timeline of infections. Again, this is just a rule of thumb. The first month of transplant, usually what you find is whatever infections you get from the hospital, or whatever came with the patient before they transplanted, or whatever came with the kidney, in this case, or any other organ. After that, usually the first few months, after the first month, is when you see the opportunistic infections. It never goes away. The risk is there. But usually after the first year, it goes down. We're kind of shifting this timeline further down the year because we're using more and more potent immunosuppression. So you have to put all of this in context. You have to know what patients come in with most of the time. Our patients have a huge number of huge risk of urinary tract infections. We manipulate their urinary tract. We put different things. They already come in with bladder issues for some of the diabetic patients. You have to treat them well because short-term treatment, your single-dose medication, once a day, one thing, or 3-day treatment doesn't work. These are not your garden variety patients. The other thing is when patients come with infection, they do not behave the same way that most patients who have infection and are not on immunosuppression. They behave completely differently. You see them in clinic, they say they're not feeling well. If you send them home and they come back later on, they probably are going to end up in ICU. The rates the infection progresses in this patient is very, very fast. So you shouldn't take anything lightly. You have to take everything very, very seriously. I'll skip through malignancy and kind of say a few words about what we do for improving somebody's chance of getting transplant. If you have antibodies, you cannot get a transplant, what can you do? There are things you could do. This is no longer a new thing. It's been done now for a few decades, meaning most donors are brain-dead donors, meaning their heart is beating, the organs are perfused, but we're still using people who are heart has stopped, and those actually make about 10% in some areas, even higher, of all transplants, and they are actually very good source of kidneys. But the other is making use of paired donation. And this is one thing we are not doing yet and we have to do because those are options for people who are highly sensitized or are ABO incompatible. And there may be options for those, especially for the ABO incompatible ones. So the concept is you cannot give to your own donor, to your own recipient, swap around, and maybe that would work. You can do it 3 ways. Or you can do it in what's called a chain, meaning somebody gives to another, and you go down, and then it keeps on for many cycles. This sometimes it is started by what's called a non-directed donor, meaning they come and say, just like what Dr. Grusner said, I want to give my kidney or liver to whoever comes. In that case, it was a directed donor, but they don't mind giving to anybody. You have to be sure that they are in the right mind when they're saying this, but a lot of people are, and after you go through your evaluation process, if they are, then they start this kind of chain that may not have happened because all these pairs are incompatible with each other.
The caveat here is so you do have an altruistic donor that gives the other, gives to the D, but then you put the donor of that R, you impose on him basically that he now is going to give his kidney to someone not related to him, or someone that he has planned to. Now, he has a risk of 1 in 8,000, which is relatively small, but it's still a risk. So you don't always find a donor then once another altruistic donor comes forward that then is still willing to donate it to someone else. Just imagine for yourself. I'm sure most of you would be willing to give a kidney to your kid, your parent, but imagine your kid or parent now gets a good Samaritan kidney. Would you still want to undergo the procedure for someone completely else? So this is a concept that when we talk to donors, we usually do not explain to them. And some of these chains have unfortunately not worked because at some point, some donor had said, no, I would have only given it to my mother, and I'm not giving it to someone else. So these things you have to keep in mind. This is great. It has been published, but unfortunately, in reality, very often you then deal with the situation. I was willing to do everything for a loved one, but I'm not willing to do the person that I wanted to donate to. Because the Good Samaritan is not given, just by chance to someone. You run the list, and then whoever's the number one, gets that thing, unless what we call a directed donation. So sometimes Good Samaritan accountant says, I only want to give it to an 18-year-old woman from South Africa, or whatever it is, and then you're limited as what you can do. But in general, these things can happen. That you try to do your best in making the change possible, but it just doesn't work.
So imagine the amount of work we do for evaluating live donors. Now add this twist to it, that there's the possibilities that somebody may renege on their promise. And there's also the additional burden. We'll talk about this when we're talking about live donation this afternoon. There may be people who are coming in half-heartedly or even not willing to donate, but they may feel that they are forced to come forward because their family pressure or living situation somehow force them to come forward. And you can find a way to get these people off the hook. You can say, okay, they cannot donate, then you cannot tell you why. But now, if they are in this, it makes it even harder. So it's not easy, and the amount of work you have to do to coordinate, because most of these things do not happen in one center. You're going to coordinate with many centers. So the legwork you have to do is enormous. The judgment you have to do is enormous. Don't minimize it.
And the surgery has to happen at the same time. Because it could be that, one of these pairs is already the transplant process, donation process, but the other one hasn't started yet. And then suddenly the donor reneges. And this whole thing, crumbles. So if you do it at different centers, the ORs have to be done at the same time. The donors go into the room at the same time. That is crucial. The recipients can be plus minus the same. But the donors have to start at the same time so that there is not a last minute change and this whole thing falls apart. Logistically, it is very difficult. That's one of the reasons why it's not done at many centers. And unless you have the infrastructure, which we don't really have right now. Is that fair to say?
Well, we don't have a living donor coordinator, so I'm going with
so we
no.
don't have we don't have the infrastructure to make it happen. But if we ever do it, then the donor recipient pair that we have here has to go to the room at the same time as they do it in Beta or whoever we are partnering with.
And even if we do just a two-way switch, that means 4 surgeries happening at the same time. So even for doing something internally, the logistics for the OR is not small. But it's been done, and it could be done assuming you have the resources. It would be good to be aware of what's going on. And be familiar with the terminology. Said non-direct and donor. The donor that's left while we're waiting for the next change to happen is called a bridge donor. And those are the ones you are afraid they may back out. It has happened. This was about 60 people, 30 kidneys, published in New York Times some time ago, and there's even a longer chain that happened afterwards. Again, it could be done with a lot of work, but the work is even more than the typical work we do. Now, I want to just finish with this slide. This is the operating room scene of the first successful kidney transplant, but this, I'm sure you have seen almost every transplant talk. But what I want to add to this is this comment that was made a year before this happened. This was said by a surgeon in Britain who was just as prominent in his time as the team that did the first surgery in Harvard. And he said, we should never try a kidney transplant in case one works because it hasn't worked so far. Don't even think of it. Less than a year later, it actually happened. So we are thinking of things that are questionable, maybe cannot be done, but things come from unexpected corners and change in ways we do not anticipate, and we hope there will be good surprises in transplant. And with that, I finish and answer any questions.
We're just going to change things up a little bit because we got delayed a little bit beforehand. So Dr. Brusner is going to give his, I don't know, it's on here, it's on the computer. And then Dr. Noor and Maxine, so we're a little bit out of order. And my presentation about the allocation will actually be moved to the afternoon.